the other ways that really, really helps is one thing that we were emphasizing right now is very much lived experience, the voice of lived experience on obesity. As you can tell, I think my own lived experience having chronic disease it becomes a form of expertise because your experiences navigating these systems are really instructive because there can be theoretical ideas about how we should all work together and they just don't translate. It helps to understand why, but also equally, hey, here's some shortcuts and solutions and co-benefits that you may not have thought of from a purely academic or policy perspective.
The HFA Pod is sponsored exclusively by Hapana.
So welcome to the HFA Pod. I'm Anton Severin. I'm Vice President of Research at the Health and Fitness Association. And today we're exploring how the global conversation around obesity is evolving and why lasting success requires more than any single intervention alone. Joining me is Johanna Ralston, CEO of the World Obesity Federation. Johanna, welcome to the HFA Pod.
Thank you, Anton. It's a pleasure to be here. Again, I'm Johanna, and I am based. Our organization is based in London, but I'm here in the US, and very happy to be meeting with you.
Yeah, we're very excited to have you.
Mm-hmm.
So, Johanna, you've spent much of your career working at the intersection of public health and global policy. To kick us off, I'm wondering what brought you to the obesity field and the World Obesity Federation, and how would you describe the role of your organization today?
Obesity, I think obesity found me rather than I found obesity. It has been such an interesting topic and an enormous privilege to be working in this area. I've worked in global chronic disease with a particular focus on federations and policy for over 20 years. I first worked in with American Cancer Society, but was head of global strategies and working on cancer control capacity building and developing in less resource countries. And then with World Heart Federation, I was CEO of that organization for 6 years. But throughout that whole time, there was this parallel. I was working on all the sort of global chronic diseases, the main ones, cardiovascular, cancer, diabetes, chronic respiratory. But there was this sort of rising shadow of obesity happening, particularly since sort of, over the course of my career, particularly starting in kind of the 1990s. And yet it wasn't really getting attention. It was a little bit kind of spoken about, poorly understood. And what was clear to me as I worked in this space was that there was much more to this than, oh, people just need to eat less and move more. There was a lot of interesting things going on metabolically. I had a family member with schizophrenia who was on clozapine, responded incredibly well to it, and had intractable weight gain from it, and really struggled with that. He'd had some underlying health issues anyway, but he passed away quite suddenly from a cardiovascular event in his early 40s. And that really had an impact on me. But again, and then when I worked in cardiovascular disease, we kept talking about the impact of the risk factors of tobacco. And there was talk about unhealthy diet, but it was so clear that there was so much more going on. And so that is why I was really pulled into obesity, really wanted to pursue it. And when the opportunity came up to take on the CEO role, I was happily accepted it.
So, from your vantage point, you're clearly been immersed in this conversation globally for quite some time. So, you've been part of that journey. How would you describe the global conversation around obesity today? Like, is it finally moving in the right direction, or are we still kind of lagging behind the science? Would you say?
I think what I would say is that there's not the conversation. There's probably what I would identify as three different conversations. If I'm honest, there's probably more than that. But there's the three that I kind of cross and traverse are, and hopefully my organization is helping to shape. The first one is really, I'm seeing a lot in particularly in US and Europe, and it is around very much around treatment, the arrival of these new therapies, incretin-based therapies. Incretin is the hormone that stimulates insulin secretion. So you have GIPs and GLPs. The That has been transformative. It has had a much greater impact than any of us would have expected, and I think it's been incredibly positive for people really starting to acknowledge obesity as a disease deserving of a health solution, as well as solutions around, as well as sort of mitigation around physical activity and around healthy diet. But that's just one piece of this, and then pricing gets in the mix as well. The second conversation I'm hearing, or we're seeing and being part of, is around this wider issue of metabolic health. Metabolic health is this catch-all term that I don't think anyone really has one single definition of. But that does include diabetes. It includes sort of the metabolic related diseases, kidney and liver diseases associated with unhealthy metabolism, essentially, and obesity. But it's also a little bit of a catch-all. It doesn't accurately really fully capture obesity. And then there's this third conversation that I think we're really trying to shape and really trying to encourage, which is we're not saying it's either or. We're not saying it's treatment versus prevention or treatment versus addressing the food environment, and especially to the point of our partnership, physical activity. It's a both and. It's all of those things. People are not just one thing. And people living with this are affected by it, which turns out to be about half the world at this point, are facing both the challenges coming from those different areas, both their own underlying metabolism, genetics, biology, stress, all these different elements, as well as unhealthier, ultra-processed foods, fewer opportunities for physical activity. But there's also solutions in each of those domains. The domains that are driving this can also be part of the solution. So what we're really seeing bits of and really, really, really trying to grow is kind of a connective tissue across all the different aspects, the drivers of obesity, and the ways that we can effectively address it. And say this is requires a comprehensive whole of society approach. But there's lots that can be done in the health system and very much in the area of physical activity. So that's the conversation that we hope will predominate over time. And also recognize, I think, really importantly, this is an issue of low and middle income countries, even much more so than even high income countries. The top 10 countries for numbers of people living with obesity, only one is a high income country. The rest, it's, so US, but Mexico, Brazil, China, India, not surprisingly because of population, but surprisingly because people haven't traditionally thought of India as having such a high number of people living with obesity. Countries like Pakistan, Nigeria, it's really everywhere. So what we want is an effective global response. We love the fact that there's new treatment options. They have greater co-benefits far beyond obesity. What we want to see, though, is a response and a conversation that captures how global in nature this is and how it really touches all of us.
And would you say like it's that's kind of perspective on it, that this is not just an issue in the industrialized West, that it's truly global? Is that where we still have the furthest to go in kind of advancing the global conversation around obesity?
I think so. I think that there's UNICEF put out a study last year that showed, traditionally we think in terms of malnutrition. Malnutrition often gets kind of misdescribed as only about undernutrition. And there's a sense of like, well, children are sort of overfed in the north or the west, and undernourished in the global south. What the UNICEF study showed, and it was working with WHO, with World Bank, and to some extent with our own data, it showed that in fact, in all but a handful of countries, more children are now living with overweight and obesity than with underweight. So that has shifted. And so when it becomes about children, then it's also harder to say, well, it's just a matter of sort of personal failure, or it's their own fault, that kind of prevailing narrative that's been around for a long time. It speaks to how structural it is, how systemic it is. And that was a real game changer but also to say this is not a wealthy country only issue at all in any way, shape, or form. It is all countries, and it's starts to really be a moral and a rights-based issue when children are so adversely affected by this.
Yeah. You mentioned before that it's important that we have this conversation about both treatment and prevention, right? And
Mhm.
that brings us into the topic of physical activity, and we both know that physical activity is widely recognized as very important for prevention and for overall health. But structured exercise is not always embedded in obesity treatment and long-term care.
Right.
Why do you think like it has remained relatively peripheral in many care models that we're seeing across the world? And maybe you can educate me if this is true in both kind of like the richer world and the global south and less developed world.
It's a great question. I would say there's a couple of things about it. First of all, I think in some ways physical activity itself suffers from the same issue that obesity suffers from. It's so cross-cutting and it's
Mhm.
so essential that it kind of lives everywhere and nowhere. It doesn't really have ownership, if that makes sense. So,
Yeah.
so it sort of that I know that you experience that frustration. All my dear colleagues and friends who work in physical activity in places like WHO, this sense of like, why is this not seen as to the extent there is a magic bullet, that it's pretty close to one, I would say. Um, so that's part of it, is sometimes those issues tend to not have enough champions in a strange way if they're kind of so diffuse and so cross-cutting. In the case of sort of what I was describing before, there's been a little bit of it's a this versus that type of narrative that has prevailed around. I wouldn't even call it prevention versus treatment. I happen to consider physical activity as treatment as well. I think it is treating diseases. I think it treats mental health. I think it has so many contributory factors. So, but to the extent that it's sort of lifestyle related issues versus medical or clinical issues, there's been a this versus that narrative. And that's probably partly why it's like, okay, well, if the pendulum's swinging towards treatment and management now, it's swinging away somehow from the idea that physical activity and nutrition matter, which is completely not true and isn't actually the case. I think what's wonderful about the WHO acceleration plan on obesity is it's an opportunity for there to be much more discussion and introduction of physical activity and nutrition in the clinical setting. That is to me a win. That shows that it's not the either or, that you go to the clinician for medicine and you go to the outside of the clinician for food and physical activity assistance. It's saying it all belongs together, or assistance with mental health, for example. So that's I think another reason. But I think it is also this sort of persistent lack of real ownership. It's exciting to see what's going on in China with this, because I think China, interestingly enough, their initial obesity strategy was primarily just about physical activity. Now they've suddenly sort of caught up and in the way that China does, ramped up lots of they're opening 6,000 obesity management centers across the country. I mean, they're really, really going big. But they are I don't have any indication that that's at the expense of physical activity as a really important piece of the equation, or nutrition or mental health for that matter.
Even when uh, health systems and policymakers around the world do talk about prevention in the context of obesity, do they tend to emphasize, we know, right, that you need to have both nutrition and the physical activity component, right? But just like how you describe the pendulum might be swinging back and forth between prevention and treatment, does it swing back and forth between nutrition and physical activity when it comes to prevention?
Great question. I absolutely think it does. I think so. You probably know that ultra processed foods is a topic that is importantly getting a lot of attention,
Mhm.
but also the source of lots of contention, lots of debate, lots of disagreement around what constitutes ultra processed foods, and is it in fact, the villain, if there's a magic bullet, isn't the single villain. We all want to find a single villain. That's it's more complex than that. And I think the research is still evolving. There's certainly not a much, much of ultra processed food we would probably be better off without for sure. But there's some complexities to it, and it's not that simple just yet. But that because of that focus, I feel like food has certainly received a lot of attention, but perhaps at the expense of physical activity, I think, as you said. And so that is also where I hope that our work together can try to counter that because we see physical activity as playing such a beneficial role. The other thing I wanted to say about physical activity is that I think the one challenge we in the obesity community have is the sense that because obesity was just seen as a risk factor and mostly as a matter of personal blame, it was sort of like, well, if we just have good exercise and healthy foods, that'll solve it, which then we've learned, as rates have gone up, despite all the great policies, is not enough. It's necessary, but not sufficient. I think it's also that it's physical activity is beneficial for so many other diseases, but that gets lost in the conversation too sometimes. It's like, well, this is for obesity. It's like, no, this is for cardiovascular. This is for diabetes. This is for so many issues. I have lived my entire adult life with multiple sclerosis, and physical activity is just as important as medical, as food, as clinical interventions are. It's critical, and I think that's true for so many non-communicable or chronic diseases.
Right. And I can imagine you've seen that through your career working through the cardiovascular
Yeah.
kind of section through the
Mhm.
cancer society, etc. It's
Yeah.
the evidence is clear that it's beneficial to all of these
Yes.
non-communicable diseases.
Yes.
So you mentioned earlier GLP-1s, right? And it's
Yeah.
GLP-1s has kind of been talk of the town for a couple of years now, and it's undeniable, right, that GLP-1 therapies have rapidly changed both clinical practice and the public conversation around
Yeah.
obesity. From where you're sitting, what what is the genuinely different aspect about this moment?
What is the difference about the medicines
Like
themselves?
where is like how how much of a sea change do GLP-1 the introduction and the broader accessibility of GLP-1s you know uh, impact the kind of obesity conversation and the obesity treatment and care plans? How much have it had an
Right.
impact, would you say?
I think the impact has been pretty remarkable. I knew these were coming. I've been in this role for 8 years,
Mhm.
and I was, some of the people who are volunteers are some of the scientists who have been part of the sort of the discovery, the studies. So I was aware of this broadly. I don't think I or the people that were working on these had a sense of how widespread the reaction would be, how much it would overtake the health conversation. And that has been really surprising. I would say, first of all, so within this 8 years, the first most important thing that happened that kind of, I think, had a step change in understanding of obesity was COVID, actually, because if you'll recall, early days when we didn't know what was going on, one thing that was apparent was both people at older ages, but people with higher body mass index or higher diagnosis of overweight and obesity were experiencing complications and in fact dying more quickly than others. So it suddenly took something that had been kind of hovering around the edges and made it an area of focus. And I think it helped people to understand there's more going on than just, again, eat less, move more. There's something going on here about underlying metabolic health that is making these people at greater risk of complications. So that I think set a framework. And then, within a couple of years, the GLP-1s come on the scene. I think our concern initially was that there was a risk of them being very trivial. There was so much sort of talk of, you'd hear more about it in glossy gossip magazines than you would in clinical journals, like, and everybody get, go to the Oscars and
Who's on
things
it,
like that.
right? Yeah.
That's gotten better, I think, as there's been greater understanding that these are actually really helping to save lives. And the most extraordinary part has been all the co-benefits. Certainly, that was the SELECT study was the first to show the benefits in terms of cardiovascular events of people taking these therapies and people with underlying obesity taking these therapies because obesity is sort of recognized as a disease in our systems, but cardiovascular disease very much is. So it's sort of the first bit of real proof. Here is a health outcome from these that is net very, very, very positive. Then the fact that there's, repercussions for cancer, for diabetes. Now there's these incredible studies going on around Alzheimer's, migraines. It's just every day there's addiction. There's different studies, different anecdotal evidence, and so much more that's being analyzed. I think what's also been fascinating, and I'm just telling you from where I sit, is how quickly it went from the sense of this being something very elite and expensive to something much, much, much more widely accessible. And that was driven partly because the pills became available more quickly than I think I would have expected based on my knowledge of the trials. So suddenly you were going from something that's complex that requires cold chain supply injections to pills, which then all of a sudden you can have a whole wider primary care sort of constituency that's prescribing these. And that's enormously beneficial. Then because of COVID, everybody was also much more oriented towards telehealth. And then telehealth took a whole bigger role in this. And then pricings with some of the things that are going on in the United States with pricing, it actually did help accelerate more affordable pricing more quickly. So a lot of even the assumptions that we had about how long it would take to get things done. And so then that all led to the WHO doing GLP-1 guidelines very quickly. They launched those last year. Some of our board members were involved in that, and we were able to also provide a lot of inputs into some of the language around, particularly focused on the lived experience of it. So it's been a very, very, very rapid development. And it's actually a little bit hard to say where we're going. I have a hope that we'll get this really right. We'll have something that's available, equitable, appropriately used,
Mhm.
in concert with physical activity and nutrition in as many places as possible in the world very, very quickly. That would be an ideal scenario. We'll see
Yeah.
how things play out.
Yeah, no, I think we're all very excited to kind of see where this thing goes and others
Yeah.
where the true tried and this next generation of weight loss drugs
Mhm.
as well on the
Yeah.
horizon. You did mention, right, that it is the science is clear that GLP-1 usage needs to be paired with lifestyle changes, so like
Mhm.
exercise and diet. Uh, do you think like so far that we're getting that right as a kind of as a society, right? Like I think there is some level of that, right, that you see in guidelines, but at the same time, when you talked about like the role that telehealth has played in the rollout of this,
Yeah.
like you
Yeah.
see the advertisements all the time, like it's not really front and center. Uh, so are you concerned that we kind of are losing that kind of complexity of it and rather that in the national psyche, like it is kind of positioned as a standalone treatment and miracle drug?
Yeah, it's a good question. Well, I think it's certainly true that that there are there's a segment of the population, particularly depending on how closely you're working with a healthcare provider, who are perhaps thinking just using the medications is enough, and not being adequately followed up, and I think gently nudged into sort of monitoring wider changes and wider complementary benefits like physical activity. That's true certainly in the US and in a lot of places. I mean, there's so much people ordering these therapies online, and it's sort of a wild west of much more so than, I mean, just so many different uh, changes converge to make these widely available, and compounding when they weren't available led to compounding now, which shouldn't be happening. So there's a lot of different things about the quality even of those therapies. Um, the best and optimal way, particularly in places like the US or in many European countries where you're going to have specialized specialists in this and experts in this, is to have, kind of a team-based approach with different competencies across the team to help the individual living with overweight and obesity. So somebody have, support for nutrition, support for mental health, all the different other elements, right? But
Mhm.
that's lots of people don't live in places where that's even that realistic. And a lot of the delivery is happening through primary care or will be. I think of the Pacific Islands or the small island developing states, they have the highest rates of obesity in the world, as much as 70% obesity in some countries in the Pacific. They're not going to have multidisciplinary teams managing it when they really almost only had primary care. But there may be places where the innovations come through really, really good telehealth that's followed up and well supported by strong primary care. So that's what I've said. I don't know how this story will unfold in different places as different parts of the world tailor sort of the therapies to their needs and realities.
Right. No, that's a good point. Like
Yeah.
a comprehensive care model, like will the groundwork and the abilities for that in a country like US is certainly not going to be applicable across very different healthcare systems, right? So I think that will be key, right, to figure out how that those genuinely comprehensive models look like in
Mhm.
less well-resourced like healthcare systems, right?
Yeah.
Yeah, like just continuing on the point a little bit with how exercise and lifestyle change like features with GLP-1 therapy. So like I think a lot of the attention in this space on the importance of structured exercise has been focused on the impact on muscle mass loss. That's
Hmm.
some studies have shown, right? That if you take GLP-1s but don't pair it with exercise, particularly resistance or strength training, like that your muscle do atrophy, and that's to some
Yeah.
extent happen with all weight loss, but it seems to be happening at a greater pace when taking weight loss drugs. Um, but I think like what's often missing is more the kind of like the elemental impact of GLP-1 therapy without structured exercise, right? And how the weight tends to come back very fast. And consider, especially when you consider that most GLP-1 users today like do discontinue treatment within the first or second years, right? And then they on average regain like 2/3 of the weight they previously had. So like it's like even taking out the risk for muscle mass loss and the kind of the risk for the health risk that comes from that, even when you take that out and just focus on like the weight regain and the detrimental health impact that is having, like I think it's that really underlines the need to kind of to really stress the need for lifestyle changes and exercise in this combination. And uh, uh, as you know, like HFA recently put out a new economic impact study that looked
Hmm.
exactly on this impact. Like we took the scientific research that's out there as of today and looked at what will happen with a population that just takes GLP-1s versus a group that pairs their GLP-1 therapy with structured exercise, and found that there is, significant not only public health benefits, but also downstream economic benefits from that. Because if you don't, yes, you invest, you as a society, you as a healthcare payer, you invest in these treatments, and then the weight is regained, and it's a lost investment in a lot of senses. I was wondering what your reaction was to that framing that we wanted to kind of convey with that study.
We strongly support the economic framing, and that is So whatever else, ideologies aside, preferences aside, bias aside, the
Mhm.
economic case is so clear, in general, and then specifically to what you have, the study that you've just completed. It is especially clear that when, again, as you said, when there's sort of structured exercise around GLP-1 sort of prescription and course of treatment, it works better, it's more effective, and there's cost savings. And I think also it speaks to the important, it helps reinforce that the investment is not just in the therapy, but in the comprehensive approach that includes physical activity, which is so important because that has, of course, there's human resource implications for that's going to cost a bit more at the outset. And yet you put a really good case forward for the cost savings over time. To back into just contextually, when we were in 2019, we commissioned, or we started a study with Research Triangle Institute that became our cost of inaction on obesity work that we did. And we had a steering group which was led by experts from our community, also from World Bank, and there was someone from OECD there to help come up with a methodology. And we landed on percentage of GDP, the cost of inaction on obesity as percentage of GDP, by which we meant mostly cost of illness, lost productivity, premature mortality. And it was it's the shortcut answer is it's about 2% of GDP as of 2019, and was projected to double in the world. So that's very, very, very avoidable expense. So in that was a good sort of, not crude, but sort of rough, broad headline. And then I think that the work that you've done, now that there are therapies and much more tangible ways to invest in addressing obesity in the health system, I think is really fantastic, because I think the thing I said as I worry about is that we would wind up with fragmented narratives where physical activity and narrative and nutrition are over here and treatment is over here, instead of understanding physical activity as a critical element of frankly, treatment, and of well-being for all.
Yes. So as we, with the spread of GLP-1 therapies and with the pairing with structured exercise that needs to come with that, that would mean a greater integration between the health and fitness community and the
Mhm.
kind of obesity treatment community. Uh, in like in your mind, like what would it take to move from that kind of collaboration in principle to greater integration in practice between healthcare systems and the fitness sector?
That's a great question. That is a really great question. It's funny because I'll just tell you a funny little personal anecdote. When I was being treated for MS. I don't take any medication for MS any longer, but I'm a beneficiary of great therapies for that. I remember kind of interacting with the fitness community while I was struggling with some side effects and feeling like felt like such a different world of these hyper healthy triathletes. And here I was, struggling with, it can feel like a very different world, and yet it really isn't. And so I think there's sort of a cultural piece to it that I hadn't really thought of before, but that I just mentioned, that just trying to find the common language and understand the shared goals. But in terms of, so first of all, there's the fitness industry, and we're certainly we're pleased, for example, that the Sporting Goods Association now is a member in official relations of the World Health Organization. That's something that was approved just this past May. And that becomes a chance, I think, for much greater dialogue inside the WHO, which is the world that I mostly operate in at the policy level. I think that those conversations happen all around the world at cities and countries, and in terms of at the policy level. And I think that dialogue is incredibly important. I think you can have great success. The models where it's easier to accomplish are in cities or small countries, because it is just inherently easier to get different groups that are working together. So it's a slightly different kind of set of interests, but there is this whole common aim around healthier environments to live in. So I think that as I said, we've been really pleased, and it's been incredibly important to us to be having this, partnership with you to continue to exchange information to really amplify that. We have our International Congress on Obesity in Mexico in 2 weeks, 2.5 weeks now from now, and certainly we have sessions on physical activity. It's always been a key part. I hope that we can make it an essential part. Um, so that we can really move this forward and shape that understanding. And I think one of the other ways that really helps is one thing that we were emphasizing right now is very much lived experience, the voice of lived experience on obesity. As you can tell, I think my own lived experience having chronic disease it becomes a form of expertise because your experiences navigating these systems are really instructive because there can be theoretical ideas about how we should all work together and they just don't translate. It helps to understand why, but also equally, hey, here's some shortcuts and solutions and co-benefits that you may not have thought of from a purely academic or policy perspective. But so kind of bringing that I would say really capturing and engaging with people with lived experience of obesity, and particularly so many people, so many amazing people we know who before the GLP-1 era were really blamed and stigmatized
Mhm.
for what we now understand as a complex chronic disease. And so who tried all sorts of exercise, who tried the biggest loser model, all this thing of just exercise for hours a day to get through this. Those people are your allies and your experts. So I would strongly recommend that we help facilitate real engagement with people with lived experience who can speak to, all the great ways that we can work together.
Yeah, and that's incredibly powerful to hear about your own lived experience with in the case of MS as well. And you know, certainly like the majority of the listeners or viewers of this podcast are people on the ground in the industry working at fitness facilities. So I think that is it's important to convey that kind of perspective and experiences you've had, and just wonder like if there are other kind of uh, takeaways that you think it's important for fitness facilities to ensure that people living with obesity like encounter supportive environments rather than stigma or judgment. That's
Well, thank you. No, I would say definitely there are really good tools to even evaluate, sort of self-evaluate attitudes and potential hidden biases that we have about this. And I think it's important as businesses in this space to engage in this. I can always feel just as a person living with a chronic disease, I can feel when I mean, I do lots of yoga, I do gym, but I can feel when a facility feels like in some ways I would be the most important person there, which is kind of how I want to feel, that they would understand that helping everybody to feel comfortable, welcome, and attended to is really important. Um, so that's probably I think there's lots of useful auditing things, and I think that kind of lived experience interaction is helpful. But also strangely, the upside of more than half of people living with overweight and obesity, in the US and in many high income countries, and by 2035, genuinely half the world at current rates will be living with overweight or obesity, is that everybody's touched by this. Everybody's affected. It's not that anybody working in the fitness industry hasn't known or been related to or experienced themselves uh, how challenging this can be. And so I would draw on that personal connection.
right. No, absolutely. And I mean, there's obviously lots to do here. And all kind of areas are key. Like, or what are you talking about, like staff qualifications or how you kind of structure your programming for different demographics and also like how you communicate with these groups. Like, if the health and fitness industry like were to take a kind of systematic approach to like be a better partner to the kind of obesity care community, like where do you think is the best place to start? Like, is it education? Is it kind of programming or something else?
Well, so actually, I was thinking about that, and it's funny when you talked about staff qualifications. One thing that's been very interesting lately in the working in the space is there's suddenly a lot of experts, and I say that both happily, but also like, what do we mean when we say expert? What does it mean to be an expert in obesity? Well, for sure, there's a clear body of knowledge around obesity expertise for a clinician to really understand the signs of it, but the lots of implications for that. But actually, being an expert also means being kind of able to work and to see how the different sectors can work together. I think that you can be an expert in. I mean, I think that really almost defining and owning what would obesity expertise for the fitness industry look like
Hmm.
is a great step, because I think that would then give you some coherent sort of standards to work towards. And one area that one program that at World Obesity Federation we have that almost exists to help all the people working as healthcare professionals. And by that, we really mean anybody with a clinical or professional interaction with a person living with obesity. It does not need to be a medical doctor. It can absolutely be a physical activity specialist or nutritionist. Uh, is qualified to gets the fills the gap in education about obesity that they did not receive when they were initially trained, because there are millions and millions of HCPs around the world who are not trained and receive no training whatsoever, or maybe an hour during medical school, for example. But we have a program called SCOPE, which is Strategic Center for Obesity Professional Education. But it's really helping to, and we have a certification program that is rigorous, led by our top experts, but very but doable, and most it can be done almost entirely online as needed. We do have in-person trainings happening as well in different countries, but that's just an example, and I'm sure there are others of how getting some kind of standard certification can be really helpful, because then everybody is sort of reading from the same book and understanding. And that does include a module, interestingly, on self, sort of understanding bias and implicit bias and hidden bias, because that's really important as a first step. But does include a lot of the basics, how it may affect women and men differently, pregnancy and obesity, which is a whole complex area in itself. Um, and just sort of different elements of that. That's what I would say. Those scope modules are free on our website, the majority of them, and then the certification is a program that you would enroll in. But even just the scope modules, I highly recommend people using, because they're really top tier, important information on obesity and how to manage and live with and communicate with people living with obesity.
Excellent. Okay, and that's available to fitness professionals like
Mhm.
throughout the world,
Yeah,
like as
yeah.
well.
So just on worldobesity.org.
Okay, excellent. Uh, in addition to Scope, the World Obesity Federation run a number of very important initiatives, right? And I briefly want to speak to one of them, like MAPS 2,
Mhm.
which you use to examine how prepared health systems are to manage obesity across everything we talked about here: prevention, treatment, and long-term support. Uh, Looking at the data that you have through that initiative, I wonder if you could speak to a little bit, like, where do you see the most consequential gaps today, and worldwide, but also if there are certain kind of countries or health system that stands out to you that have kind
Yeah.
of started to figure out the right way to integrate all of these components.
Sure, absolutely. And I can answer that question in terms of both findings from MAPS and also just recent accomplishments in the news. But so the MAP study we did in the first round in 2019, 2020, looking at where obesity sits in health systems in different countries. At the time, we were able to find good data for only 50 countries. So, I mean, it's good, but it's, we did report cards, which sit on our website as well, for 50 countries, showing what are the barriers and enablers, what policies do they have in place? Is obesity understood as a disease? Is it in the health system? In most cases, the answer to that was no. And in some places, it sits just in the food system, for example. Now here is, cut to sort of 7 years later. There's much more understanding obesity is in there are policies in many, many systems, but it's still pretty fragmented. We do a lot of desk research on that. We do expert interview research, and we do surveys, and we've collected now in the past year 4,000 surveys, 2,000 from healthcare professionals, 1,000 from people with lived experience, and 1,000 from others working in the space or through policymakers. And we're analyzing it now, and we'll publish it as part of the World Obesity Day 2027 and in a peer-reviewed journal. But I can tell you some of the things we're learning now. So in the initial MAP study, they said the biggest barriers to addressing obesity in the health system were lack of political will and lack of education on obesity. That's probably still true to some extent. I think political will has gotten better. I think the education piece, there's still a huge need for education, and that would very much sit, across the physical activity world as well. But the interesting thing that we're seeing with the MAPS2 survey is overwhelming responses from all those countries I mentioned that are not, what we traditionally think of as the places where, Brazil, China, South Africa,
Mhm.
Ecuador, like it speaks to an enormous hunger for being part of a global survey and set of standards. We hope that this will become the way that countries can really understand their roadmap for obesity and tailor their needs to it as effectively as possible, and then learn from one another. That's the ideal, right?
Yeah.
So I would say some of the success stories, though. So, for example, just a couple of weeks ago, France started coverage of the therapies as a public, sort of public coverage of the treatments,
Mhm.
which has been, I think, a breakthrough there. France has kind of had a lot of back and forth around obesity policy. In Italy, they've recognized obesity as a disease. Other countries, so in the UAE, in particular Abu Dhabi, they have really interesting programs. I think they're great models of what a comprehensive program, the one I described at the outset, should look like, where you have sort of childhood addressing health at the school and the educational level and in the home to the extent possible, while also having comprehensive services, building healthier environments, better access to food, and very much around physical activity, which if you know the UAE, it is a very hot place with a lot of air conditioning and not a lot of sidewalks and places for sort of healthy. Whenever I go there, I walk around the Dubai Mall to get my steps in because it's very hard to, you can go to the gym too, but it's an interesting example of a place that has had very, very rapid development, but to some extent at the expense of the healthy places to move. And I know
Yeah.
they recognize that, though, and I think they've shown real leadership and investment in addressing it, and they are really, really training up all of their physicians. So that's been great as a good example. As I said, China's interesting because there's, now that they've decided to do something about this, they're built, 6,000 kind of weight management, obesity management centers associated with hospitals and institutions
Mhm.
opening. I think, do they have it all right yet around physical activity? I would say they're probably still working through it. We're doing a lot of work with China, and we're going to be there in August. But the government is, doing what they do well, which is investing a huge amount of focus on it. India, and interesting, like the way it's similar in population size, but very different in how they go about things. They've been doing a lot of really interesting and promising things to try to address their growing and very, very, very significant obesity challenge. And I think they've been doing a lot in the area of physical activity, but you have to work more at the state level, and we're working with our members there on sort of models in 2 states to kind of get proof of concept around what works with a comprehensive approach, with scope training, with the mapping, with integrated approaches.
Okay. Yeah, very curious or interesting to hear that there seems to be more political will and action in some of these countries that we don't typically, as you say, like associate with the obesity epidemic. And I wonder if that's, you know, in kind of like the Western part of the world, like obesity is much more kind of baked into our kind of public consciousness as okay, this is part of what public health looks like or public health challenges, while it's maybe like a newer feature in some of these other societies, or what do you attribute that kind of higher level of activity or will to act in some of these other countries?
Well, I'm not sure, but I think one of the things that I think has been that we're still trying to understand so much about is in in many places, uh, larger bodies are a sign of health and wealth. It means
Mhm.
you don't have an infectious disease in some cases. We see higher prevalence in certain African countries with among adult women, and a woman in a larger body is associated with wealth, essentially, and so there's a lot of different drivers. And I think we have enough. We know that there's a lot we still don't know about why and what's driving different elements of this, um, and that whole political will piece. But I think that the one common thread through everything is there is recognition that obesity is contributing to health challenges. I should say that everybody recognizes that. I don't think that's completely true, but I know that, for example, some of our one of our volunteers from the Caribbean um, had sort of had familiar, multi-generational obesity. It was seen as favorable in her country, a positive thing. And then when she had breast cancer, because she's a doctor too, she tried to talk to doctors in her country about this and say, my breast cancer is related to my underlying obesity, and they completely didn't agree with her on that. So I think there's still even gaps in that knowledge, which translates to political will, but it isn't quite as it's not sort of rooted in stigma as much as just real misinformation and fragmented knowledge.
Right, right.
That
Yeah,
makes
no,
sense.
interesting. I know we're coming up towards the end of our conversation here. I've really enjoyed it. I think it's been very thought-provoking. To round us out, I wanted to ask you that as you look ahead, like what is it that gives you the greatest confidence that obesity care can become more comprehensive and but also like where do you see the potential pitfalls? Like what could prevent progress from happening?
Yeah, so no, I think probably you can tell from my focus on things like narrative. I think that we have a lot to be. It's a really, really, really interesting and exciting time to be working in this space. It's endlessly fascinating, and there's a thread of hope that hasn't been there before that makes it especially rewarding, I guess I would say. So I think the comprehensive element, the more we can really, really help foster that understanding that if you build a system around addressing obesity, you're building a system that's actually going to do a really good job of addressing the much wider chronic disease, non-communicable disease universe, and really be a health enabling system. So that to me is like, if you think of this as the entry point to the kind of health that I think we all want. And I know people who work in the area of fitness wish that we had more health enabling environments, more value placed on it. So do we, and so do we think that that's really, really important for the kinds of diseases that most people are affected by now or at great risk of, right? So I think if we succeed in making helping to really show that this is an entry point to wider health, a system that works for obesity is a system that works for health, we will get the job done next year because I am working in the UN space as the main policy channel, but there's a big high level meeting for heads of state in 2027 on universal health coverage and what should that look like? What are the key elements? If you say that obesity should really be one of the fundamental pieces, you can therefore prevent a lot of later deaths and even incidents, arguably, for cardiovascular disease, certain kinds of cancer, lots of diabetes, type 2 in particular, but also just generally lots of other diseases. So it could be this really wonderful case. So that's my hope. I guess the
Yeah.
risk is that it doesn't get taken seriously, that we still deal with a sort of subtle, what I would very much call stigma and bias around like, oh, obesity, but we could, that's the individual's fault. I mean, that's still in people's minds, and I think it still has this way of kind of playing out in policy. What did I hear this a colleague said recently, that people say, well, the drugs are the easy way out, and then it'll just let them go eat the unhealthy food. I mean, it's like, I don't know anybody with obesity who doesn't want to live in a healthy environment. And most have had such a strong metabolic reset that it's not about how much they're eating. It's just, it's the disease that's taken over taken over you know, their system. So I think that's what I would just say, that a fragmentation and political confusion would make that hard. That's where narrative is so important. I also think the media are very much the sleeping giant in all of this, actually. The media perpetuate some of the stigmatizing imagery and language. The media are the ones who can, through change that. And I've seen it work. I've seen the New York Times do a much better job of this. I've seen lots of media that are now saying people with obesity rather than obese people, which winds up being very stigmatizing, and showing much more sort of, we have image banks, sort of many of our members, Obesity Action Coalition and others, you can go on our websites, but images of people who are living with obesity, but also it's not that sort of very stigmatizing, the headless body of somebody gorging themselves on junk food, but really just a person living their life, trying to manage and trying to get the healthcare and the healthy environment that they need. So I think if we could get to that more of that world, we will see this as a real success story. I really believe that.
Yeah,
We're very pleased to be working with you on this.
Yeah, likewise. No, we're very excited to continue the conversation with you and your team as well.
Thank you.
Johanna Ralston, it's been a pleasure having you on the HFA Pod, and look forward to continue working with you.
Thank you, Anton. Thank you very much. Really pleasure to work with all of you. Really appreciate that. Thank you. Have a good day.
Thank you.
Bye.
Welcome to the HFA Update.
HFA recently partnered with FTI Consulting and fitness federations around the world on a new white paper exploring one big question: how do we help people get the most long-term value from GLP-1 therapy? The research points to a clear answer: structured exercise. Across 5 countries, the study found that combining structured exercise with GLP-1 treatment leads to better health outcomes and billions in economic and societal value compared with medications alone. You can download the report From Weight Loss to Lasting Value for free at healthandfitness.org.
The HFA Pod is sponsored exclusively by Hapana,